Hi everyone, this is Neil Writer, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. This is part one of this patient's extraction, and this is their right ear. I will upload part two, their left ear, hopefully tomorrow. And I have managed to take a still image of all the wax that I removed from both ears, and I will share it at the end of the video. On that particular point, I know a lot of you do like seeing all the wax at the end of the procedures, and I do try my best wherever possible, but sometimes I'm just so busy in clinic. We've got back-to-back patients, and when we're treating patients, it's not only removing the wax. We have to take a thorough history at the beginning of the procedure, debrief the patient after we remove the wax, and then we've got to wipe down, decontaminate, and then we've got to write our notes, and then we've got to get prepared for the next patient. So sometimes time just doesn't allow me to take images. So I do apologize. I know it's something that I've been reading quite frequently, especially in recent videos, but yeah, it's just time. When I'm performing these procedures, the last thing I'm in my mind is actually, thinking about uploading it later. Just the focus is completely on not only this patient, but once we finish with this patient, then treating the next patient. So now this is a real extreme case of earwax impaction. This patient has attended before, and we kind of agree that they attend on a regular basis even back then, because it was quite a complex procedure a few years ago. And laterally, so the outer wax was quite mushy, but then the deeper wax was extremely hard and impacted. It almost resembled, in terms of removing the wax, like a keratosis obturans. Now, this isn't keratosis obturans. It didn't have any ear pain. And although there was a lot of dead skin involved in this extraction, it was predominantly wax. Keratosis obturans, when you've got an epidermal skin plug, and one of the hallmarks of a keratosis obturans is otalgia, so ear pain, and you see these squams of dead skin. And what I mean by that is the outer layer of skin that lines the ear canal and also the eardrum. So the eardrum, remember, is 3-ply thick. But the outermost layer that's visible to the naked eye, it's made up of epidermal skin. So typically skin has 3 layers. You've got the epidermis, which is the most superficial layer of skin. Then you have the dermis layer in the middle, which contains elastin, collagen, quite often blood vessels and nerves, and also hair follicles. And then you've got the inner layer of skin, that is you can call it the hypodermis layer or the subcutaneous layer, which is predominantly made up of adipose fatty tissue. Now, with the ear canal, the inner 2/3 of the ear canal, it only has the outer layer of skin, the epidermis layer of skin, so it's super thin, it's wafer thin, it's about 0.1 millimeters in thickness, and that sits directly on the bony part of the ear canal, which is the inner 2/3. The outer third of the ear canal is made up of cartilage, but you also have the 3 layers of skin, so the epidermis, the dermis, and the hypodermis. So the skin that lines the cartilage portion of the ear canal is a lot thicker. It's about 1 millimeter in thickness. And the individual skin cells, they're interlocked. So the individual skin cells that form the epidermis layer, they're called corneocytes, and they're interlocked. But as the skin migrates from the deepest region of the ear canal towards the entrance of the ear, so we call that epithelial migration. So the skin in our ear, as it dies and sheds, it should move sideways, and when it reaches almost the outer third of the ear canal, the individual skin cells begin to detach from one another and they flake away individually. But with keratosis obturans, so going back to why I started explaining the physiology of the ear, is with keratosis obturans, there's 2 major things that kind of go wrong and is abnormal. Instead of the skin migrating sideways from the deepest part of the ear canal to the entrance, the skin has a tendency of migrating inwards into the middle of the ear canal, where it forms into a plug, and the individual skin cells fail to detach itself from one another, so they're still interlocked. So you have these long sheets, squams of skin, and then you get multiple layers of this skin, almost like an onion in a lamellar structure. Now, there's no real evidence of that lamellar arrangement of dead skin cells here. There was a bit of skin, and like just to the left of the suction probe there, but there was a lot of wax involved here as well. But another characteristic of keratosis obtrans, similar to what you're seeing here, you have this outer silvery white matrix of skin. So that's a fresher layer of skin that will eventually form into the core of the plug. So it could have been this is pre-keratosis obtrans. If they didn't get it treated, then it would have developed into keratosis obtrans. And also you get a global widening of the ear canal. This patient has got a bit of a widening at the floor of the ear canal, but they had that last time. Now, there was occasions where I switched to the endoscope because it was a bit of a struggle, but I actually then went back to the WAXscope. I just found the WAXscope a bit more beneficial in this particular procedure. And there's occasions where it's the other way around. So I start off with the endoscope, for example. I think, okay, let's go to the WAXscope because it's a complex case. But then I revert back to the endoscope. So having the option of both for me is really, really great. I just want to address another kind of a few comments that I've read recently. I probably addressed it before. So when we perform procedures, I'm not doing this. It's not for entertainment value. I know a lot of you may enjoy watching it for that reason, but a couple of comments recently is both with the endoscope and obviously with the WAXscope. Now with the WAXscope, there's high level magnification anyway, but I just get comments that don't enjoy your videos because you're too close up. Well, I'm performing a procedure. I want to be close up. I want to be able to see what I'm doing, particularly when we're working very close to the ear canal and the eardrum. But yeah, so hopefully I think most of you appreciate that I'm performing a medical healthcare procedure, and I'm more concerned about the view that I'm getting to facilitate the removal as opposed to what I upload later and people can then watch. So yeah, I did revert to the endoscope on a couple of occasions, but I just went back to the WAXscope. It just felt easier in this particular case. It's not always the case though. Now, initially you can see those hairs coming down from the top part of the ear canal. That's where the slot in the specular is. And it does somewhat obscure the view, but when you then pass either it's the suction probe or the correct in this case, you can see it pushes them out of the way. And I'm just trying to glide over the top, but this was such a dense impacted plug. Although I've managed to get the instrument over and beyond it. Now, a sizable piece did come away there, but it did also spread, I think, some of it at the floor of the ear canal. So I'm just going back in with microsuction. It's quite matted. And yeah, another comment as well, because it's all kind of relevant to this video, is why don't you just use forceps? And one of the videos, I actually used forceps several times, but the forceps weren't helping at that point in the procedure. And I did mention it, like I'm using the forceps here, but at the moment, there's nothing really to grab onto. So forceps it's not easy to use forceps, and it's not always possible to use forceps. For example, at the moment, this plug, it's flat. So what am I really going to grab onto? There's a bit lifted at the bottom, but the top jaw also has to grab onto something. And as I said at the beginning of this video, this particular case, some of the wax was quite mushy, and then the deeper part where we're now approaching was really solid. So when you're using forceps, you need to ensure both jaws, they can grab onto part of the wax. So for example, just imagine someone has a coin, a dollar coin or a pound coin in the ear canal, and it's completely flat. And some of the cases where I'm reading these comments is instances like that, when you've got a hard plug of wax and it's got a flat surface. Well, it's not possible to use forceps because you're not going to grab onto anything. Occasionally, you may get a plug of wax and there's a bit protruding out, but the plug is mobile in the ear. What happens is when you approach it with the forceps, when you close the forceps, initially it can actually push the wax plug further in, and the patient, it can touch the eardrum, so it can be uncomfortable. So we've got to be wary of that. So I'm just trying to wriggle this through. Starting to come away. Also, I used the correct, I don't know whether I used the ear hook. I did use it in the other ear, but the correct, I kind of felt I needed over the ear hook because it had that surface area. Quite often with the ear hook, I might use the ear hook here, kind of, let's see. But sometimes with the ear hook, what it can do, it can just cut through. But because this is a bit firmer, as I said, the wax deeper in the ear, it was a bit more impacted. You can get some purchase on it. But it did also cut through it, so it didn't fully remove it. But I was able to then use the suction and correct, I think, just to mop up. But quite often the correct that we've developed, the right correct, because it's got a tapered tip, it can embed into the wax similarly to an ear hook. Not always, but it can. And because it's got a greater surface area, you can then drag a lot of it out. So if it's a narrow ear, the ear hook or the ear pick, it's more beneficial because it's more streamlined. You can get into a narrow part of the ear, particularly with the ear pick. It's weird. You kind of, I've heard other specialists kind of mention it. You go through phases where you have a preference to using a correct or ear hook. Sometimes both instruments can do the same job equally as effectively. At the moment, I'm kind of probably using the correct a bit more. I'm not sure why that is. So I'm just trying to wriggle this through the entrance. It is quite a large plug, and it was impacted against the eardrum, and you'll see a piece of this wax stuck on the drum. So as we extracted it off the eardrum, a piece of it remained there, and it was quite stubborn. You're going to see that in a moment. There it is in the middle. And that's right in the middle of the eardrum. That's a region called the umbo. Now, at the beginning of the video, I explained the anatomy of the skin that lines the ear canal. And that outer layer of skin, the epidermis layer, it's actually secreted in this region. So all the skin that lines the ear, the outer layer of the eardrum at least, and the inner 2/3 of the ear canal, it all originates from here. This is the progenitor site, and the skin cells then radiate, they migrate off the eardrum and then line the ear canal. I've just zoomed in a little bit, but it was still very, very stubborn and embedded. So I'm going to put a bit of olive oil in the ear just to lubricate that region. There was a bit of skin left near the top part of the eardrum, but I just left that alone. It was, the oil softened that, and it wasn't a significant amount. But I wanted to get this out because this is where the skin actually begins to migrate. So I've just put some oil in, I'm just suctioning the excess oil, and you can see it just loosened that, it came away. And then they've got some dark pellets, a couple of dark pellets. They've got a little pit, the inferior recess, I call it the pit, but it's the inferior recess is quite prominent near the eardrum. So as the ear canal approaches the eardrum, the ear canal narrows and then widens both at the base, where we're going now, and you'll see that it looks like a little speck, but it's a bit bigger because some of it's hidden into the pit. And we're going to lift it up and away. You can see it's a bit larger than you would have initially anticipated. So we're just going to push they've got quite a hairy entrance. So I'm just going to focus on the eardrum. So some of that plug definitely was adhered to the eardrum, and that looks nice and healthy. So I would say, yeah, I'll probably say half of that is their right side. I think it's the plug to the left. So yeah, do stay tuned for part 2. I will hopefully upload that tomorrow. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.